So hi everyone, welcome to my webinar. Today I'll be presenting brainstem auditory evoked response, also known as ABR, BAER or BAEP. So before I begin, I'll introduce myself. My name is Chong, Clinical Application Specialist, Asia Pacific, and this is my email address. I'll have this disclaimer. NTA. So NTA is Natus Training Academy. It houses the online training, e-seminars and other congresses. This is also the website for our past webinar recording. So please log on to this website for more information. So the main agenda is as follows. First, we'll have the introduction and also the general instruction for recording ABR in Natus system. Then we'll go into the software workflow and touch on the selection of folders, protocols and tested sites. After which we will have an overview of the screen layout and going through the process of impedance check, defining stimulation intensity and the delivery of stimulus. Lastly, we'll review the online report and the commonly used features in version 22. So let me start off with the introduction. So what is brainstem auditory evoked response or potentials? Brainstem auditory evoked response or potential, also known as ABR, is useful to study the function of the cochlear nerve and the brainstem in general. It's the recording of the cortex activity that's induced by auditory stimulation. And the auditory stimulation comes in the form of headphone or using a tubular insert. The study is performed usually using two channels, and the most commonly test setting measures the short latency response, also known as the early response. And of course, we take into account there are several other groups of responses that corresponds to the whole hearing peridium. So we have the early response, we have the middle latency response, and we have the late response. So mainly there are three groups. The early response are recorded in the cortex within the 10 millisecond, followed by middle latency response that are recorded from 10 milliseconds to 50 milliseconds, even though not commonly performed in routine studies. Then we have the late response, which are from 50 milliseconds to 300 milliseconds and beyond. The tests performed to derive these responses are namely the P300 and the mismatch negativity tests, and these are mainly event-related potential tests that is used within the cognitive neuroscience field. And by using different stimulation and recording peridium, one can record the mid-latency and long latency responses as well. The different test settings are configured on our EDX, Viking Quest and Ultra Pro to facilitate this testing. So the recording of the potential on the cortex is equally challenging because the response are very small. Therefore, we use a technique that's called averaging to extract the revealed potential from the actual potential. So in the end, we average the signal to create a mean waveform out of the stimuli. So as you can see, there's a direct signal that's coming in, and the direct signal goes through the process of averaging, and after which it comes out with an average signal, and the average signal is then amplified to show up in the display. So another aspect of auditory stimuli is the stimulus polarity, and stimulation comes in different directions. The condensation is basically applying the positive pressure onto the tympanum in the ear, whereas the refraction is doing the opposite, applying negative pressure onto the tympanum in the ear. Lastly, we have the alternation, which is the alternate of both, and this is done in the interlifting manner. There are also various stimulus patterns in the system setup, but mostly we use the click for BAEP. Clicks are usually monophasic and consist of the full frequency band. Peeps are clicks with specific frequency, mainly used for patients with a frequency that is specific in range. On the other hand, we have peeps with different envelopes, and they are mainly used to better extract responses in auditory or audiology testing. We also have the tone bursts, and they are mainly used in late responses. So the ABR stands for auditory brainstem response. BAER stands for brainstem auditory evoked response. Both are essentially the same test, and these tests evaluate the integrity of the cranial nerve number 8 at several levels on a broad range of hearing frequency of 2000 to 4000 Hz. So as you can see from the curve, this is the BAEP curve, or ABR curve as you call it. There are several peaks. So we have peak 1 all the way to peak 7. So each of the peak represent a specific level of the auditory hearing pathway, and this basically gives you a functional assessment of the entire auditory pathway at different levels. So what's important here is more of the prominent waves. So the 1, 3, and 5 are the most prominent wave of the ABR curve, and wave 1 represents the distal spiral ganglia and auditory nerve. Wave 3 is the ventral cochlear nucleus that's in the pons. Wave 5 is lateral meniscus in the lower midbrain. And of course, wave 7 is the terminal branch that's going into the primary auditory cortex. And based on the guidelines of ACNS, we have some reporting to make. So in terms of stimulus type, the clicks of 100 microseconds rectangular pulse is recommended based on ACNS guideline. There's no preference for refraction or condensation, but as we all know, the routine studies usually use refraction as the technique. However, alternation gives much poorer resolution but reduces the stimulus artifact at the same time. So by all means, the stimulation is applied on 1 ear at one time. The stimulus rate can be between 8 to 10 Hz and sometimes go up to 11 Hz. Stimulus intensity is very subjective. It's recommended to be 115 to 120 decibels SPL, but this is mainly in adults and it varies in different age groups. A masking noise is recommended on the contralateral ear to avoid crossover response, and other stimuli like peeps or tone bursts can be applied for different application. For this example, peeps may be applied for frequency range specific testing. So in terms of the recording electrodes are placed on CZEC, A1 and A2. The mastoid are alternative to A1 and A2. So we don't recommend to put on FZEC because if you put it on FZEC, the amplitude may be reduced. And essentially we will definitely need a ground lead. And the impedance of the electrodes must be kept at a low level, preferably to be under 5 or 10 kilo ohms. On touch, if you are stimulating on the left, A1 to CZEC would be your ipsilateral, and A2 to CZEC would be your contralateral, and vice versa. Recording parameters are as follows. So recording length of the time base is minimum 15 milliseconds for the sweep duration. For filter, it's 10 Hz to 3 kHz. If there is a muscle or surrounding artifact, the settings can be changed to 100 Hz to 3 kHz. Number of average is between 1000 to 4000, so we kept it at about 1500 as default setting. That would be fine. Patient can be awake, asleep, or lightly sedated. And when we do the testing, what we derive is the ABR curve, and the ABR curve gives us very useful information in terms of latency and response, and also the amplitude response. So we're interested in mainly 1, 3, and 5, and also the peak latency difference of 1 to 3, 3 to 5, and 1 to 5. So this is where we can see whether there's any prolongation of the latency or any change in the reduction of amplitude. And for amplitude, we are interested in 1 and 5 wave because that's what is needed to do the calculation of amplitude ratio. Plus, we need assessment of reproducibility and asymmetry. So reference value can also be established based on the stimulus polarity and stimulus frequency rate, stimulus intensity, and applying the similar stimulus duration. So below is an example of normal values at stimulation rate of 10 Hz with a stimulus intensity of 90 decibel SPL. And you will see at different peaks there will be a latency response as well as a standard deviation that's behind it. The same applies for amplitude and also the interpeak latency difference. So for this webinar, it will focus on the standard ABR or BAER test as described by the ACNS guideline. So this is the default setting, and they are solely based on the guidelines of American Clinical Neurophysiology Society and the textbook Evoked Potential in Clinical Medicine by Professor Chapa. So just some general instruction. For our system, we can perform ABR tests using either Viking EDX, Synergy EDX, Viking Quest, and also Ultra Pro. So just do note that systems do differ in their screen appearance, function key, and arrangement of amplifiers. And just to remind, these are general guidelines. So just some difference between the hardware system. So here we are looking at the AD2+6 amplifier EDX, and this can be used to select their inputs using the software controls, very convenient. Viking Quest and Ultra Pro, they are slightly different because they have hardwire connection. So if you use this system, one will need to reconnect the electrodes when tested site is changed. And when the same electrode is used on different channels, a jumper cable will be needed to make this connection. So in terms of patient preparation, the headphone has to be calibrated. Patient has to be seated or lying in a comfortable position. New prep gel to prep the skin surface. 1020 gel to stick on the electrodes. And then you can also tidy up the electrode cables to reduce the noise. Impedance to be kept under 5 to 10 kilo ohms. If you're not able to keep, at least keep them balanced in terms of the impedance level across all the electrodes. And for mounting of the headphone, the headset, make sure that the red is to the right ear and the blue side is to the left ear. So this is what is illustrated. So make sure you put on the electrodes in the correct position, and A1, A2 is in position with CZ as your reference, and you have a ground electrode at FPZ preferably. And then you mount the headset on. Make sure the right side of the headphone is going to the right ear, and the left hand side, which is the blue color, is going to the left ear. So in terms of testing, we place the electrodes, we check the impedance, we put in the headphone, and we look for the patient's hearing level. So what we're doing here is the determination of the hearing threshold. After you have determined the hearing threshold, you add on another 75 decibels to the hearing level, and you wait for probably a couple of seconds, maybe 30 seconds, and before you start the actual recording. So the test is performed on each ear, and 2 trials must be performed for each year, at least for reproducibility purpose. So duration of study can be about 30 minutes, but we do suggest that if the patient cannot cooperate, we can start with a higher intensity. So selecting the procedure is very simple. In Synergy platform, and also in Ultra Pro system, the evoked potential tests are organized in their own test folders. So all you need to do is basically select the desired configuration and then choose the protocol, and you're set to go. So if you're using refraction as your mode of stimulation, you just have to make sure that you choose the correct test folder, choose the correct protocol, and hit on to the correct test site, and you can begin your acquisition. For the Viking EDX and the Viking Quest, the Viking platform has it slightly different. The EP test folders are basically accessed through the EP icon. So we go into this thing called the EP icon, and from there we choose the test and we choose the protocol, and you can also choose the test size, and after which you can log on to the acquisition screen. So this is the main acquisition screen layout. So what we have here is the test screen, and the test screen shows the menu bar and also the toolbar that's right at the top. And these are the main system components of the window-based program. The screen is then divided into three parts. So the left side of the window is used to display the trace. And so you will notice there's a sensitivity and sweep settings that's just next to the trace, and these are indicated by yellow arrows. So you see better over here. And we also have on the other side, which is the right side, we have the result table, shows the absolute latency measurements of different waves and also their differences. So just below we have the marker panel. It appears below the trace and is used to manipulate the markers if necessary. The status panel is seen below the monitor trace. It tells you about amplifier connection status and the mode of acquiring. So the function keys are situated at the bottom of the screen, and they are mostly color coded. So if the amplifier is off, the monitor trace will appear flat. The amplifier indicator in the status panel will be gray. The impedance function key will also be grayed out, so indicating that the function is not available. So just like all other EPs, impedance check is essentially important. The goal here is really to measure the impedance between the electrode and the skin that overlies our skin surface. This is important because it impacts significantly the signal to noise ratio of your ABR or BAER recording. So it's recommended to at least have a very good impedance level, preferably to be under 10 kilo ohms. 5 would be even better. So we turn on the amplifier, we press on the impedance function key. The system will now show a new window that describes the montage that's used for recording. So the input used for testing are shown with black fonts. So this means that they are active inputs. The inputs that are not used for testing are in gray font, and this means that they are inactive. So it makes it very easy for you to identify the active and the inactive, as well as identifying the connection to the amplifier inputs. Just do note that the labels used in the software may not necessarily match the labels on the amplifier itself. So one should always check on the physical input of the amplifier and also the screen to make that connection. So after you connect the electrodes, click on OK to proceed. So when impedance check is selected, the recording montage is displayed to facilitate the connection. And the impedance value updates every 2 seconds or so. So if impedance cannot be reduced, then one should try to get similar values on all the electrodes to at least have a balanced approach. And click on OK when impedance are successfully done, or at least of a satisfactory level. So the stimulation settings are shown in the menu bar. The desired stimulation intensity in this default setting is 75 decibels above the normal hearing threshold. So what we are going to do now is to measure the hearing threshold. So we click on the threshold function key, and the dialog box will come up. It will show the control for assessing the threshold. At present, the left side is selected for assessment, just based on the figure below. So you click on the stim on, which is the red arrow here, and then you change the intensity in steps of 1 or 5 decibels to help you find the hearing threshold level. And after you have found the hearing threshold, leave the setting at that level. So one can also do the same for the other side. So this is the hearing threshold assessment for the right side. So let's say if it's 7 decibels. So maybe on the left hand side is 6, and then for the right side is 7 decibels. So the stimulus intensity level is automatically adjusted by adding 75 decibels to the threshold. So take for example, now we are doing the left hand side. We will have 75 decibels as the standard default setting, and plus another 6 decibels for your hearing threshold. That will give you a total stimulus intensity of 81. So that's what is showing on the screen right here. So the user can also define their own intensity level that's above the threshold. So once the intensity is being set for, you can simply start your acquisition. And you have selected average. In this instance, it will start to collect and average the potentials. So in this illustration, the signal averager is turned on by default. So you can also see that through the status panel. And do also take into account the monitor trace, and it should at least appear flat or also called stable, indicating minimum noise and interference, because significant activity in the monitor trace may indicate high or mismatched electrode impedance, or possibly noise, movement artifacts, and etc. So all of these will actually have an effect on your ABR recording. So when signal averaging begins, the first 10 sweeps are rejected automatically. The signal averager also excludes trace that have high amplitude. So those high amplitude can be, for example, noise or interference, and this is basically called artifact reject. So the waveform is at least obtained when 1500 sweeps are average, and they are basically clean sweeps. So that would be the first estimate of the ABR response. So the system automatically saves it and begins a new trial, or replicates the waveform to assess the reproducibility of the potential, and this is done using the EP program. So after you complete the second trial, the acquisition and stimulation will stop automatically. So this is the default for replication in the EP program. But if you take this away, if you turn off this automated mode, the data collection and stimulation will stop after you complete the first trial. So from here and beyond, it is like a manual mode of recording. So for your second trial, you just have to click on the next replicate function key, and this would save your current trial and then provide you a new set of blank trays for recording. So this is the function of next replicate. And from here, you can just push on the acquired key to start stimulation, and then start to average the waveform. So the user can perform up to 6 replication if necessary. So in a good quality recording, the two trials should at least have a very good superimposition. The number of sweeps averaged and rejected is shown to the right side of the trace. So the rejected will be in a bracket. The positioning of the markers on the trace can be adjusted using the mouse or using the keyboard control. The marker position are used to measure the latency, the values, and the differences can be shown up in the result table. So one can also define normal values of measurement and use them to highlight normal and abnormal findings. So this can be a user setting that can be changed. So here you are reviewing the waveform, and then you click on next side to begin the testing on the opposite side. So notice that the stimulus intensity is automatically set using the earlier hearing threshold that you have established. So they have automatically remembered that hearing threshold level and input that to the stimulus intensity. And from here you can check your monitor trace again. If it's clear, if it's stable, and patient is ready, you can start your acquiring. And once you are done with your ABR testing and you got all the responses that you require, you can just simply exit the test by clicking on the function key. So here we look at the report. So you can click on the report icon. You will generate a Word document. So on the Word document is the ABR test report. So the report shows the latency for the individual trials and also the individual channels, their latency difference, and also the amplitude changes in the response. Side-to-side comparison can be made. Traces can also be included in the report for easy reference. So this is just one example. So let me just touch on the last part, which is the commonly used features. So there are many things that we can do with the tracings that we acquired. So one thing is, of course, replication. So the system allows one to perform up to 6 trials, or we call it 6 replicates. A new trial can be initiated by pressing on the next replication function key, like we mentioned earlier. So the control to select a trial or replicate is actually shown on the left hand side, which is what I've indicated here by the arrow. So you can choose specifically on each of the trials or each replicate to look at each of them individually, or you can click on the sigma icon that's right at the top here, just below the A1 side, and that will give you an average response between these two trials. So as you can see in this illustration here, the two trials are performed, and the trace associated with the current trial are shown in light orange. So the associated measurement are shown in the result table. So in this example, you will see that the second trial is being selected. So the trace from the first trial is now shown in light blue color as indicated in the background. So by clicking on the number 1 in the control, you can then select the trace and measurement from the first trial for review. So this is basically what you want to see. If you want to just see on the first trial, then you just have to click on it, and that will give you the measurements from the first trial for review. If you want to click on the second one, then you will select the second one, and that will be the measurements from the second trial for review. If you want to get an average of all the trials, then you click on the sigma symbol icon, and that will give you an average response of the two. And this is also what we call the average replicate. Yeah, so the average replicate is to get an average of all the trials that you have collected in the replication. And if you want to redisplay the individual trial, you can click on the replicate function key again to revert. The marker panels are just below the trace, and the tools are available to manually add, remove, or display or hide individual markers. It lists all the markers that are available for identifying the different responses. You can also have it defaulted to set the markers on individual wave, like wave 1, wave 3, and wave 5, based on the latency range. And markers can be also placed manually by the customer, so we offer plenty of flexibility, so you can have it automated, allowing the system to put the markers for you, or you want to have it manually controlled. We also have this feature called auto comparison. So auto comparison basically brings out the comparison of the trace as well as the table, the result table, and this can be done in a one screen format. So you'll be able to see the values on the left hand side as compared to the right hand side, and also look at the waveforms from the left to the right. And there may be also some instances that you may encounter frequency noise, so trace can be slightly smoothened to reduce this frequency noise. So this function can be applied to the traces. One can select different trace by using the control key on the keyboard, and you just click on the desired trace that you want. You can also select the individual trace by selecting on it itself, and it will show up in yellow. To select all the trace, simply just click on the trace window. So if all the trace are in white color, means that you have selected all of them. And for the smooth trace, we adjust mainly two types of setting. One is the number of smooth to apply. The other one is the algorithm number of points that you use. Smoothing is actually a function that only reduces slightly the amplitude of the response, and it will not really affect so much of the latency. So it can be really used to reduce some frequency noise or interference that may be interfering with your ABR recording. And do note that we also have other trace manipulation functions, so you can go to results in the menu bar, then you click on functions under the drop down list. Then we have things like trace inversion, rectification, and refiltering. We can also restore the trace by using the restore function. So sometimes if you have placed the electrode in the opposite way, so trace inversion will help you to put it into the right position. And if you have a very noisy or unstable baseline, you can do a rectification of the signal to bring the baseline to be a leveled manner. If you have if you have frequency or interference during your recording, you can also choose to do a refiltering as a part of the post-processing process. So this is one of my last few slides. I will just give you a short video clip to show you the entire sequence of next replicate function. So right now I'm just going through the low frequency filter, high frequency filter, make sure we are in the right settings. We check on the stimulus intensity and the stimulus rate, and make sure the transducer is set to autometric. So the transducer is basically audiometrics, and it's connected to our TDH headphones, and we are doing it in the rare fraction mode. So we already did our first trial using site number 2. Then we'll continue to average for at least 1500 times, and you can see the number of average that is next to the average sweep is about 19 now. Yeah, so you have 19 reject sweeps compared to what you are averaging right now. So you average it for about 1500 times. And from here you will also see that the waveforms has already been established. Most of the prominent ABR curve has already been formed. So we see wave 1, wave 3, and wave 5 very prominently, and the auto markers are being set up. So you will see that the markers are placed correctly on each of the waves. So all I need to do later on is just some very fine adjustments. So right now we're done. So you see the next replicate comes in because I already hit that button earlier on. So once you finish that first trial and you finish averaging, it will quickly jump into the next subsequent trial automatically, and it will be sitting right on top of the first trial as your first trial is going into the background. Okay, so we just forward the process, and you see that this is a very good recording. The waveforms are almost superimposing each other, and the markers are basically done up quite properly. Yeah, so what I need to do is really to do some fine adjustment for 1, 3, and 5 wave, and also put on some manual markers for 2 and 4. So in this case, I'm selecting the individual trial of number 2. Okay, so that's about it. So let me just put on the citation of the reference. And this is the end of my webinar. I thank you for all your attention. If you have any questions, please feel free to get back to me. Alright, thank you.